Dear colleagues, it's a great pleasure for me to meet you in this digital way, the EAO 2020. I'm grateful to Dentsply Sirona Implants for inviting me to discuss with you a very hot topic, and that's the management of peri-implantitis. My name is Derks, and I have my home at the University of Gothenburg in Sweden. Before we now address peri-implantitis and its management, I would just like to highlight and emphasize a concept that was made at the 2017 World Workshop in Chicago, and that is in diagnosing peri-implantitis. The primary parameter is the clinical assessment, and that is using the periodontal probe, assessing both probing pocket depth and bleeding on probing. It is this assessment that guides us in diagnosis and then also in treatment. The radiograph is added and is of course also required, but it is secondary and then only supports these primary findings. And it's not so much the one-time radiograph as you see here. It is rather the change over time, capturing, as in this case, the progressive bone loss that we connect with peri-implantitis. And taken together with the clinical findings of bleeding and probing, of an increased probing pocket depth, we then come to a diagnosis, a proper diagnosis of peri-implantitis. So through my talk now in the next couple of minutes, I will very much emphasize the clinical parameters that you can see indicated here on your left. And does this make sense? This concept now highlighted in 2017, but we now have also data to support this concept. Because if we focus on bleeding on probing first, it's a simple and quick assessment that you can repeat. And it shows you on the slide to the left here that it is very much connected to a history of bone loss. That is, if you find circumferential bleeding, the risk that bone loss has occurred is multiplied. That is, of course, a clear indicator to follow up with a radiograph. And not only that, if we add the millimeter scale, the probing pocket depth, also this parameter is a strong indicator for bone loss. Given here that with an increase of a probing pocket depth of 1 millimeter, you can expect an increase in bone loss of 0.3 millimeter. There's a strong correlation between these two parameters. So my point here is that the clinical assessment that you can cheaply and easily repeat on an annual basis are the ideal measures to monitor implants over time. Because we have to consider that peri-implantitis behaves in a way that it has its onset rather early in most of the cases, and as indicated in the two pictures to the bottom, it typically progresses rather fast. So a tool, a clinical tool that allows us to monitor implants easily over time is required. And this cannot be the radiograph, because we can't take regular radiographs without the clinical indication. So this is something that is very important to us in our concept, and that is the periodontal probe. Now, before we move on discussing both prevention and treatment of peri-implantitis, we have to address the etiology of the problem. What causes peri-implantitis? And I will give you an easy and straightforward answer, because in our mind, the problem, the etiological factor, is plaque. It's the bacterial biofilm that causes the problem. Now, how can I argue that this is true? There are basically two ways in addressing this question. The first way to answer is what you see here, and that is that patients that are not attending a supportive care program, that are not performing adequate plaque control, they are at much higher risk of developing peri-implantitis. This has been shown over and over again. This is clear, but has its weaknesses, as it is a retrospective assessment. So the second way to answer the same question is actually the stronger answer. And let me illustrate this by showing you a case where we treat peri-implantitis. You see the signs, both clinical and radiographically, that are consistent with the diagnosis. And then we treat. And when I say treatment, I mean we are using an anti-infective approach, including an access flap, that is access to the contaminated implant surface. We clean, and I will indicate in a minute the workflow as we treat, but basically we clean. So very much in line with what you know about periodontitis, the treatment of periodontitis. And if we then allow the case to heal, and I'll show you here a follow-up at the 1-year assessment, we see that first and foremost we get rid of the deprobing. There's an absence of bleeding on probing. And then in line of this, in line with the clinical improvement, we also see the response on the radiograph. That is, we have a remineralization, a defect fill. And let me point out to you that no bone graft was used in this case. This is an open flap debridement. When I say anti-infective treatment and cleaning, these are some clinical illustrations of what I mean. So we have a contaminated implant surface that and you see to the lower left, the important tool that we use, and that is a rotating titanium brush that cleans these implant surfaces. And just by looking at them, the clinical impression shows you that the surfaces are clean. Now I'm showing you one successful case and a couple of clinical illustrations, but I will back this up with convincing clinical evidence that indicates that in the long term, using this approach, the treatment of peri-implantitis will result in stable bone levels. In other words, the disease progression that I showed you could be quite fast in the majority of cases, arrests. Meaning that if we remove the etiological factor, the biofilm and the plaque, the disease process arrests. And that is today the strongest proof that plaque bacteria are the etiological factor behind peri-implantitis. I will, however, make one exception where I see a different pathway, and that is related to fractures of the implant. And this is something that, in my opinion, if I may speculate, is something that we underestimate. Fractures of the implant are an initially mechanical problem that then takes on the form of peri-implantitis. So many of these cases indicated here by an example, they are diagnosed as peri-implantitis, but they turn out to show a fracture, which in my mind is the initial etiological factor of the problem. So here the underlying problem is mechanical in nature. If we move now to the concept of prevention, and we now agree on the primary etiological factor being plaque, then it is quite obvious that in constructing our prosthesis, our superconstructions, we have to allow for proper plaque control. And this is a balance in many cases, a balance between the need for cleaning, the need for access, and of course the aesthetic demands by the patient. And we have to manage this balance as clinicians. But if we're talking prevention of peri-implantitis, we of course have to make sure that access for the patient is possible. And not only access to the patient, we have to make sure, as we are now addressing bone level implants, that we choose correct components for the soft tissue integration. In other words, please don't use too short abutments that will move the prosthetic platform close to the bone. No, we should rather allow for proper dimensions for soft tissue integration. If now the prosthesis prohibits proper plaque control and access for the patient, we have to adapt these prostheses. And this is something in our hands, is an everyday aspect that we change and adapt our superconstructions. We also have to redo superconstructions as a preventive measure. Ideally, a crown that you see here to your lower right should of course be redone before a problem occurs. And in that, this is to me also a preventive measure. I will go even further. As we now have a better understanding of risk for peri-implantitis, there's one factor that stands out, and that is the periodontally susceptible individual. Patients such as this, that according to the new classification would be categorized as a stage 4 periodontitis. Now, what I'm aiming at is to discuss treatment planning. We should maybe reconsider such patients in particularly that are at high risk of developing peri-implantitis, because we may reconsider using teeth to restore such patients to an extent that is a larger extent than what we are used to today. So it is patients like these that we may treat with old concepts rather than using implants, and that is what I'm talking about, is reducing the number of implants in risk patients. In this particular case, we're using extensive tooth-supported restorations, minimizing the risk for peri-implantitis, of course. I will move on now to treatment concepts of peri-implantitis. I'm repeating myself and saying that the treatment in this particular case is guided by the presence of bleeding on probing indicated on the slide to the lower middle. So it is not so much the probing depth itself, it is not so much the radiograph, it is the presence of soft tissue inflammation. The diagnosis seen in this case is of course clear. It is peri-implantitis. Now in these couple of minutes now, I will focus on the advanced case of peri-implantitis. I will not talk about mucositis or the early incipient forms. These are established cases. And our understanding is that non-surgical approaches are rarely sufficient to treat the disease in its entirety. Surgery is usually required. And this is what I would like to address. But please, don't get me wrong. The patients still undergo non-surgical therapy. We give time for healing, but we also give the patient the understanding that in a second stage, surgery will be required. Whenever possible, we remove the superconstruction. We create full thickness flaps, so it is very much a periodontal therapy, with one particular difference indicated on my next slide. What is possible in the peri-implantitis situation is to raise the flap and immediately separating the inflammatory lesion from the flap. So what you see here is the lesion remaining in the defect surrounding the implant, but I have elevated a clean flap. This will facilitate your treatment and speed up the process. In the next step, we remove this inflammatory lesion, as in the case in the upper lateral indicated before. We will now chip off, I'm sorry, I'm just moving to the left. We will chip off hard deposits using titanium-coated instruments. And we will then use a rotating titanium brush to decontaminate the surface. The irrigation used during this step is saline. At no time do we use any other antiseptic or local antimicrobial. This is purely saline, and we have some evidence to support this concept. We use gauze, also soaked in saline, to debride. And you can see the long gauze to the lower right used for the palatal or lingual aspect. Following this decontamination, we have to make a decision as to whether we want to graft or not this particular case. And to your right, I am indicating some cases, some examples where we choose to graft, and I will discuss with you the concept whether we should or should not graft in a minute. After grafting, we close the case and then also place the superconstruction back on the implant. Removing the superconstruction during surgery tremendously facilitates the procedure. So whenever possible, this is what we do. Then, according to the periodontal protocols that we have, we follow our cases. Plaque control is re-established from the patient, and then it is reasonable to probe at 6, at 12 months, and a radiograph should follow not earlier than 12 months. So it is a case like this, indicated now by the picture, where we initially have deep probing exceeding 10 millimeters. We reduce, pronounced reduction of the probing pocket depth, and I will add the radiographic image. In this particular case, we use the graft at the 12-month control, which is secondary because the main outcome to me, and I will underline this in a minute, is the reduction of probing pocket depth and the absence of bleeding on probing, in particular the absence of circumferential bleeding on probing. Just some examples of cases where we did use a graft to your right, and some examples where we simply cleaned and replaced the flaps to your left. Of course, the graft is in place also at the 12 months. We can see it radiographically. So it is a little bit difficult to understand what has really happened. If you look closely at the cases to your left, it is easier, because whatever happens in terms of remineralization, radiographic defect fill, that is, of course, these are tissues, the patient's own tissues. And this kind of defect fill, of course, goes hand in hand with healthy, soft tissues. Right? And I will continue a little bit on the grafts in a minute. But to be honest, in our day-to-day practice, in many of the cases, we actually go for an immediate pocket elimination. So the concept of cleaning is the same, but we then also adapt the sharp edges of the bone. We push down the tissues so that we immediately following surgery get rid of the pockets. And this is something, of course, that has aesthetic consequences. But whenever we are in the posterior, this is to us the treatment of choice, the most predictable treatment. And that's the case, a lower first molar indicating an outcome at 1 year of such a treatment. So in the last couple of minutes, I would just like to address the use of systemic antibiotics as an adjunct to this treatment. I would like to discuss with you the surface decontamination, the protocol that I showed to you, and then my answer to the patient in terms of how long does this last. In other words, what are the long-term outcomes of such treatments? The use of systemic antibiotics has been evaluated in controlled studies. And if we look at one from our own group, we have an outcome at 3 years, a positive outcome at 3 years, ranging around 70%. We have, in other words, continuous bone loss in the remaining 30%. These are the outcomes at 3 years. And if we split now for the use of antibiotics, because this was the randomization in this particular study, you see the outcomes at 3 years indicated by the yellow bars, and the groups separated on the x-axis are both the use of antibiotics and no antibiotics, and also indicated the type of surface modification of the implant. In other words, the modified surfaces versus the non-modified smooth surfaces. And if we look at first at the non-modified surfaces, that is the two blocks to the left in the graph, then you see that the antibiotics did not add anything to the outcome. It was equally good, with a probability of success ranging around 90%. It is to the right, in the modified surface group, that there was a difference. We reached 80% at 3 years using antibiotics, while it is as low as 30% without antibiotics. So what we advocate today is that your choice of antibiotics as an adjunct to surgical therapy should be based on the surface characteristics of the target implant. If it is a non-modified implant, no antibiotics are necessary. And the concept as a whole indicates that the treatment of non-modified surfaces is much easier, is more predictable than the same at modified surfaces. I will move on to surface decontamination. And you have already seen us using the rotating titanium brush as the key instrument in our workflow. I will add now some support based on in vitro lab study, using an electron microscope to evaluate different modalities to clean. In this particular study, no bacteria, no contamination was involved. This was simply an evaluation of the effect of instrumentation on the implant surface, using to the right two different versions, to the middle and right, two different versions of a titanium brush, and to the far right an air abrasive. Comparing this to a regular ultrasonic scaler and to a modified tip. If we take a look at the microscopic images after treatment, clearly we can see that the use of the ultrasonic scaler to your left leaves behind a surface that is more or less destroyed, tremendously rough. The three groups to the right indicated that the treatment reached all parts of the thread, that is, both the valleys and the tips of your implant threading, without destroying the surface. So these kind of data indicate that both a titanium brush rotating, but also an air abrasive, are feasible instruments to decontaminate without destroying the implant surface. So this is to us the choice without any clinical data from this particular study, but a concept study indicating that it is a safe procedure to use in our patients. I will move now towards the prognosis of this kind of treatment. You've already seen some data on a 3-year basis, but I will now present to you some brand new data that is actually addressing the question of risk for recurrence or disease progression following surgical therapy of peri-implantitis. And this is now on a 5-year database, on a 5-year axis. That is the risk between year 1 and year 5 to develop recurrence or progression defined as either bone loss, implant loss, or the need for renewed surgery. And the numbers are as follows. Based on 130 implants, we found that as much as 44% showed signs, any kind of signs of progression or recurrence. This is the situation today. Now, protocols have certainly improved, but this is the situation, the latest data today that we have. I would like now just to indicate, and this brings me back to my initial statement on how important clinical measures are, indicating here the strongest factor predicting progression or bone recurrence. And you see it already indicated. The strongest factor is the probing pocket depth at 1 year. So in other words, my initial outcome of treatment is a strong predictor for what will happen in the long run. And we broke this group into 2 parts, that is shallow probing, less than 6 millimeter, and residual pockets, if you want, of 6 millimeters or more. And you see the rate of progression in both of these groups. We are very strong in the group to the left, that is shallow probing, reduced risk of progression, while if we have residual pockets, we basically have a problem, because then the risk of progression or recurrence is as high as 80%. So this brings me to my conclusion, and that is that the primary goal of peri-implantitis surgery should be the reduction of probing pocket depth. So it is shallow probing that we would like to achieve. And this is very much in line with the diagnostic principle that shallow probing is consistent with stability in the long term. And with this, I would very much like to thank you for your attention. Again, thank you to Dentsply Sirona Implants for the invitation. Have a good day.